Hi. I'm happy to say that after Rohit and Rekha's talk, I won't have much to add. So this will be very quick for all of you. From a medical oncologist standpoint, I think for us, squamous cell and adenocarcinomas have been different for a long time. But unfortunately, the trials have clubbed both of them together. They are different entities, risk factors are different, prognosis is different, their responses to treatment is different. We should know that surgery alone can still cure about 15% of the patients. Radiation alone in squamous cell carcinomas can cure about 35% of the patients. And we don't know in squamous cell carcinomas if definitive chemo-RT is equal to surgery, but we think it might be, and that will always be open for debate. So how do we see somebody with an esophageal cancer? If they have an adenocarcinoma of the esophagus and a good performance status, then we go with perioperative chemotherapy with FLOT. This is based on the ESOPEC trial, which showed that chemotherapy is probably better than chemo-radiation, and there is an improvement in survival. So if you have an adenocarcinoma esophagus and a good performance state patient, then FLOT is the way to go. If it is an esophageal squamous cell carcinoma, then we do the cross regimen of chemotherapy radiation with weekly carboplatin paclitaxel followed by surgery. For patients who are not eligible, who are not fit for chemoradiation, and we see a fair few of these, who are not fit for surgery, then we take them for definitive chemoradiation. So the question is beyond, where do we go from here? Where do we go from FLOT in adenocarcinomas and chemoradiation in squamous cell carcinoma? So this is a trial Rohit already spoke about in detail. So this is a patient with adeno and squamous cell carcinomas, the Checkmate 577, where we tried to see if adding immunotherapy is going to make a difference. And we selected those patients where after the completion of chemoradiation and surgery, if they had any residual disease, that is pathologically they did not have a complete response. So these are patients where we think that the disease is going to recur. These were the patients who were randomized to nivolumab or no nivolumab, and we found that there was an improvement in distant metastasis-free survival and improvement in overall survival also by close to 7%. So, and all the subgroups pretty much benefited from addition of nivolumab if you didn't have a pathological CR. So following the cross radiation, the future now is that nivolumab immunotherapy improves survival in patients who have not obtained PAT-CR after concurrent chemoradiation and surgery. Now, what about if we give them FLOT? Is there anything we can do better from there? So this is a trial called the Matterhorn trial, which is hot off the press kind of, and where in addition to FLOT, we are trying to give chemotherapy, immunotherapy also, Durvalumab, and see if that is going to make a difference. So patients with GE junction adenocarcinoma, so not technically esophageal maybe, but GE junction, so that would fall in the scope of this talk, where we added Durvalumab to FLOT and then took them for surgery, and again adjuvant Durvalumab for up to a year. Again, there is an improvement in event-free survival. Overall survival seems to be leaning towards the positive, but we don't have the data yet. But based on, and pathological complete responses have also increased from 7 to 19%. So based on this, hopefully once the overall survival data comes and we have more mature data, we think that the addition of Durvalumab immunotherapy to perioperative FLOT in patients with gastric and GE junction cancer, which has an improvement in event-free survival and PAT-CR, will also likely lead to an improvement in overall survival. So these are my conclusions, that immunotherapy has made significant inroads in the treatment of both squamous and adenocarcinomas. Nivolumab is definitely the new standard of care if there is no PAT-CR, and Durvalumab should be considered in addition to neoadjuvant FLOT in eligible patients. The talk was PD-1 therapy and beyond. Unfortunately, there is not much beyond happening right now, so I will end here. Thank you.